Welcome, everyone. Thank you for joining us for today's webinar. My name is Christina, and I'm the Administrative Director at Stress and Anxiety Services of New Jersey. Today, Dr. Haynes will be presenting Assessing for OCD, giving the Y-BOCS, other measures, and differential diagnoses. This presentation is part 2 of our 11-part ERP training series. If you have purchased the entire package, you will receive a certificate of completion at the end of the series. If at any time you are unable to attend the live series, a video recording and test will be sent to the email you have registered with in order to get your CE certificate. Dr. Haynes currently works as a senior psychologist at Stress and Anxiety Services of New Jersey. She is a cognitive behavioral therapist who has been trained in the treatment of anxiety disorders, including OCD. She has also been trained in the treatment of trichotillomania and PTSD. Dr. Haynes has also been trained in the SPACE program, a program for parents to help their children with behavioral issues. Just a little housekeeping before we begin. Dr. Haynes will be answering questions during the recorded portion of today's webinar via the chat box. During the last 10 minutes, you will have the opportunity to ask questions live. Any questions that she does not get to, you can email her with the email address provided in the survey that will be sent to you at the conclusion of today's webinar. This survey needs to be completed in order to receive your CE certificate. Certificates will be sent to you by Tuesday of next week. If you do not see them in your inbox, please check your spam. And if you still do not see them, please shoot me an email. And now we will begin.
Good afternoon, and welcome to part 2 of Stress and Anxiety's webinar series, Exposure Response Prevention for OCD Training. I'm Dr. Cindy Haynes, and today the topic is Assessing for OCD, giving the Y-BOCS, other measures, and differential diagnoses. Just first, I'd like to say that there are no conflicts in my presentation. There are no conflicts of interest. Today's goals will be to understand the Yale-Brown Obsessive-Compulsive Scale, how it works and how to score it, and using other measures to assess as well, such as the Obsessive-Compulsive Inventory and the Florida Obsessive-Compulsive Inventory. We're also going to look at differential diagnoses, diversity and differential diagnoses, and barriers for minority populations. So just a quick recap. Obsessive-compulsive disorder is a neuropsychiatric disorder that many times develops in childhood. To meet criteria, the client must experience the presence of recurrent, unwanted, and intrusive thoughts, which are obsessions, and/or repetitive behaviors or rituals intended to relieve the distress. Obsessions are unwelcome and distressing ideas, thoughts, images, or impulses that repeatedly enter your mind. They may seem to occur against will. And compulsions are behaviors that the patient may feel they have to perform. So the gold standard for assessing OCD in adults ages 18 to 80 is the Yale-Brown Obsessive-Compulsive Scale. What you're looking at on your screen is the Y-BOCS symptoms checklist, which I believe you also were sent a copy of. This rating scale is designed to rate severity and record the types of symptoms in a client diagnosed with obsessive-compulsive disorder. In general, the items depend on the client's report. However, the final rating is based on clinical judgment of the interviewer. So you're going to rate the characteristics of each item during the prior week up until and including the time of the interview. And score should reflect the average occurrence of each item during that week. The rating is a semi-structured interview. The interviewer should assess the items in the listed order and use questions provided. However, you're welcome to go and ask your own questions as follow-ups. Additional information could be furnished by others, such as a spouse or a parent. So before proceeding with the questions, what you would like to do is define obsessions and compulsions and avoidance for the client. So an example of an obsession would be, you might be responsible for killing a loved one. Compulsions, on the other hand, are behaviors, and a compulsion might be, I have to wash my hands to rid myself of that thought. So we're going to go over the categories in the Y-BOCS, and you will notice that on the left, it says current, and on the past is right next to it. So current would be, is the client experiencing this now? And the past would be in the last couple of weeks. So the first part is aggressive obsessions. That includes the fear that you might harm yourself, or that the fear that you might harm others. Violent or horrific thoughts. Fear of blurting out obscenities or insults. A fear of doing something embarrassing. A fear that you will act on an unwanted impulse, such as stabbing a family member. And a fear that the client may harm others because the client was not careful enough, such as running somebody over in a motor vehicle accident. Or the fear that the client is responsible for a fire or a burglary because they may have forgotten to turn the stove off or didn't lock the door. So those are listed under aggressive obsessions. Contamination obsessions include concerns are discussed with bodily waste, which include urine or feces or saliva. Excessive concern with environmental contaminants, such as asbestos or toxic waste. Excessive concern with household items, such as cleansers or solvents. Excessive concern about animals. Excessive concern with sticky substances or residues. The client is concerned that he or she may get ill because of a contaminant, or that he or she may make someone ill because the client was exposed to a contaminant. There is also a category where you are afraid of contamination, but not because of harm. You just can't stand the way it might feel on your body. Next category is a difficult one. It's sexual obsessions. And many times people have difficulty with sexual obsessions because it's a hard thing for many people to admit. Because this category includes forbidden or perverse sexual thoughts, images, or impulses, which can include children or incest. Content could involve homosexuality, and it could also involve sexual behavior towards others in an aggressive way. Many times, parents have overwhelming, intrusive thoughts that they're going to harm their child, either sexually abuse them or physically harm them. They don't want to admit it because of fear that perhaps the interviewer doesn't understand or doesn't know how to adequately assess for OCD rather than pedophilia. So sexual obsessions, you're better off if you approach them in a very non-judgmental, very easygoing kind of way because of the fear that many people have about this. There are also hoarding and saving obsessions. The fear of not holding on to something may cause bad luck, or not being able to get rid of something because it might have value. There are religious obsessions known as scrupulosity, and this is concern with sacrilege or blasphemy. I once had a client who couldn't go to church because he was a devout Catholic and had intrusive thoughts about Jesus Christ and the Virgin Mary. So exposures had to center around that, which was very difficult for him, but he was able to do it and go back to church. There is also excessive concern with right and wrong or morality. There are also obsessions with the need for symmetry or exactness, which can be accompanied by magical thinking and maybe not by thinking. So not by magical thinking. So for instance, if you touch something 2 times with your left hand, the client may feel they have to touch something 2 times with the right hand. And the magical thinking accompanying that might be the world will end, or there will be a bombing, or I will be responsible for a murder if I don't touch or tap. It can also be accompanied by not magical thinking, which means that it's just the feeling of not having things lined up or in symmetry makes you feel so uncomfortable that you kind of, it's called just right OCD, that you have to just have that feeling that everything is okay. There's also miscellaneous obsessions with a need to know or remember, a fear of saying certain things, a fear of not saying just the right thing, a fear of losing things, intrusive nonviolent images, intrusive nonsense sounds, or words or music. The client could be bothered by sounds or noises, lucky, unlucky numbers, lucky, unlucky colors, superstitious fears. Then the Y-BOCS moves on to obsessing for somatic obsessions, which include a concern with illness or disease, an excessive concern with a body part or aspect of appearance called dysmorphophobia. Then after that is done and all the obsessions are assessed, then the Y-BOCS looks at cleaning and washing compulsions and other compulsive behaviors. So the first one that the Y-BOCS assesses for is cleaning, washing. So excessive or ritualized hand washing. Ritualized hand washing could include how many times the client pumps the soap dispenser, how many times the client turns the spigot on or off, how the client may dry his or her hands. Excessive or ritualized showering, bathing, toothbrushing, how many squirts of the toothpaste does the client use, grooming, toileting, or any other measures designed to prevent or remove contact with contaminants. The next compulsions are checking compulsions. How many times does the client, check the locks, the stove, the appliances? How many times does that checking occur that the client did not harm herself or others? How many times that nothing terrible happened? How many times is that checked? How many times is it checked that no mistake was made? Or any other checking behaviors tied to somatic obsessions. There are also repeating rituals. Many times students run into trouble because they have to reread or rewrite. So rereading could include not feeling that the chapter was understood or the sentence was understood. It can also include the client believing that he or she did not get all the words on the page, even words such as and or the client may feel they have to go back and check to make sure that all the words were gotten. Also, rewriting. So the client may feel that they're writing something that is offensive, and so they'll erase the sentence and rewrite it again, or that letters are offensive, that the way the letters look are not correct. And somebody could look at that and go, oh, that handwriting is terrible. So the T's may not be crossed as though the person wants them to be, or the I is not dotted appropriately. And so rewriting could include erasing to the point that paper rips, or that it's even sloppier when it's done because of all the rewriting. And this can also happen when emails are involved, because you could be afraid that you're writing offensive material in an email. So you're constantly looking at that email and rewriting it. The Y-BOCS had been revised years back to also include a section on avoidance. So avoidance includes avoid doing things or going places or being with someone or not being with someone because of obsessive thoughts. So the client could avoid contact with that person or avoid contact with contaminated objects or people. The person could avoid handling sharp or dangerous objects or operating vehicles or machinery out of concern that he or she might harm others. The client could avoid contact with people, children, or animals because of unwanted impulses. The client could avoid talking to or writing to others for fear they're saying the wrong thing. The client could avoid watching TV or using internet or reading to shield from disturbing information. The client could avoid doing things or going places or being with someone that would target or trigger consuming rituals. After the Y-BOCS is given, the client is asked to rate on a target symptom list the items that give the most distress. And that's usually 3 or 4 items that the client is upset about in the obsessions category and also in the compulsion category. The symptoms are rated over a week using a 5-point scale, which goes from 0 to 4, which is extreme. The 5 dimensions that are measured are time and frequency, interference with daily life, how much distress does this cause, how much resistance does the client go through, and what is the degree of control. The scoring is 0 to 40. 0 to 7 is subclinical. 8 to 15 is mild. 16 to 23 is moderate. 24 to 31 is severe. And 32 to 41 is considered extreme. Again, the Y-BOCS is the gold standard for OCD assessment. It comprises a symptom checklist and the severity scale and is grouped according to content. The next measure we're going to discuss is the Children's Yale-Brown Obsessive Compulsive Scale. That is also considered the gold standard for assessing OCD in children. It is semi-structured and assesses presence and severity in children. But the questions, while similar to the Y-BOCS, are more developmentally appropriate. Okay. It is scored similarly to the Y-BOCS as well. The other measures that are used, one is called the Obsessive Compulsive Inventory Self-Rating Scale. Self-rating instruments are important because they're often done outside the office, and people can be more relaxed at home and maybe more truthful when not facing the interviewer. So the measure consists of 42 items that include washing, checking, doubting, ordering, obsessing, neutralizing, and hoarding. Answers are scored on a 5-point scale, a 5-point Likert scale, again, 0 meaning not at all, 1 meaning little, 2 meaning moderate, 3 is a lot, and 4 is extremely. Scores range from 0 to 168. 42 or more indicates the presence of OCD. It is not diagnostic. The Florida Obsessive Compulsive Inventory lists 20 items. It is derived from the Y-BOCS. It assesses symptoms over 1 month, and it captures impairment and interference. So questions include contamination, keeping objects in perfect order, images of death, unacceptable religious or sexual thoughts, worry about terrible things happening, very similar to the Y-BOCS, but a much shorter inventory. So the review of tools and techniques, the Y-BOCS and the PSI-BOCS are the gold standard and are used for assessment and diagnostic differentiation. Self-report instruments, like I just went over, are generally completed quickly. They are independently administered, and they provide a level of comfort, as I said, because people can answer them in the comfort of their own home. Other measures that are used is the Child Obsessive Compulsive Impact Scale, which assesses severity and impact, and the Children's Obsessional Compulsive Inventory, which assesses level of impairment. The next assessment, which is a very valuable assessment tool, is called the Family Accommodation Scale. And the Family Accommodation Scale consists of several items that assess family involvement in the client's rituals and obsessive thoughts. So there are 12 questions, and they are: question 1, have you reassured the client when she expresses worries, fears, or doubts related to obsessions or compulsions? For instance, reassurance that disturbing thoughts are unfounded, or that she or he has cleaned enough. Do you help him or her complete rituals or other obsessive compulsive behaviors, resulting in interference with plans you have made? Do you wait for him or her to complete rituals or other behaviors, resulting in interference with plans you have made? Have you put up with things that the client has done that you would prefer she did not? Are there things that you do not do or say because of OCD? Do you assist him or her in avoiding people, places, or things? Have you helped him or her undertake or complete compulsions, providing excessive quantities of soap, for instance? Have you engaged in compulsions or behaviors that you consider odd or senseless at the client's request, or because you thought he or she would want you to do these things, like cleaning, checking, repeating, ordering? Lots of times people will put the laundry away a certain way just not to upset the client, or separate the clothes according to color, something like that. Do you help complete tasks or make simple decisions when symptoms interfere? Do you modify social, work, or family responsibilities because of OCD? Do you modify what you consider ordinary family routines because of the symptoms? Do you currently do some of the things for the client that would be his or her responsibility if he or she didn't have OCD? If the spouse or the parents or the family members have marked yes, ask them to consider how often and how much time is spent doing these things. And this is very helpful in helping. This scale measures accommodation in helping a child complete rituals as well as adults. So, differential diagnosis. How do we know it's OCD, and how do we know if it's not? or if it's something else. So depression many times is confused with OCD because in depression, many times people have rumination, perseveration. They hold on to a topic where they can't think about anything else. Now, normally when the person is not depressed, he or she may not have these thoughts. So it's very important to determine when the thoughts started and did it come with the depression or before the depression? And because the distinction could look, it could look very much like OCD, even though it might be a clinical depression. Does the person have generalized anxiety? Is this person a constant worrier? So worry without compulsive behavior, it could be a worry about someone's parents, it could be a worry about getting sick. It could be worries about not getting good grades. And that would be more of a generalized, wide-reaching anxiety rather than an obsessive thought that causes severe distress where you feel you have to do a ritual to relieve the horrible anxiety. Panic disorder can also look like OCD. Somebody is so afraid of getting panicked that all they do is think about getting a panic disorder. So one of the hallmarks of diagnosing panic disorder is, does the person live in fear of the next panic attack? So that person could be thinking constantly about that. And that could be mistaken for OCD because of the constant feeling of a panic attack coming on. And so and maybe the person engages in behaviors to avoid panic, like not going to a public place because they're afraid of getting a panic attack. Phobic disorders are very often confused with OCD. The distinction in phobic disorder is that if someone, for instance, is afraid of dogs, the phobia would be of all dogs, not just golden retrievers or German shepherds, but all dogs. In OCD, the fear is usually very localized. So for somebody with contamination who's terrified of getting a germ and washes their hands 50 times a day, might be able to go out and walk in the mud. So it's very localized to what the actual fear is, whereas in phobia, it's more general. It's not specific. You're not afraid of only a certain dog, you're afraid of all dogs. Anorexia is also sometimes confused. The eating restrictions. So it's very careful to ascertain whether the person is restricting eating because they're afraid of something happening where they might get sick, or or they may not, or they might be afraid that if they eat, they'll look weird or something like that, as opposed to anorexia or an eating disorder, which you're very much afraid of the way you look and the fear of getting fat. Obsessive compulsive personality disorders, OCPD, a person can have OCPD, not have OCD. You could have OCD, but not have OCPD. And OCPD is characterized by rigidity, a real inability to make change and to have everything an exact way. It can be confused with OCD. And obsessions, compulsions versus delusions. So obsessive compulsive behavior, many times the client has a sense of reality attached to it. So they'll say, I have to wear the same clothes or I'm afraid I'll flunk the test. And if you question that person, he or she might say, well, I sort of know that, I won't flunk it, but I feel like I have to, that I must. That is different than a delusional belief, which does not have reality attached to it. So that person could say, no, it's absolutely true. I must wear the red shirt on the day of the test, or I will not pass that test. And that's a fixed belief. So delusions are fixed beliefs. Obsessions and compulsions usually have some reality attached to it, because delusions, again, are beliefs. Obsessions are thoughts not necessarily believed to be true. So someone that believes that they are, someone who has a thought that they're a pedophile might say, but oh my gosh, I would never harm a child. That thought is repugnant to me. I could not ever do that. So there's a sense, there's the reality testing is there, as opposed to a delusion, again, a fixed belief. Symptoms of OCD can be seen in Tourette's, autism, and frontal lobe lesions. In autism, you can have an autistic disorder and also have OCD. But in autism, as well as OCD, there is a lot of rumination, there is perseveration. So sometimes autism can be confused for OCD and vice versa. Tourette's, the repetitive movements, there is Tourettic OCD, where people feel they have to, lift their shoulder or make a movement. So there is you can definitely have Tourettic OCD as well. So obsessive compulsive related disorders share characteristics of OCD in symptom profile, in biology and treatment, as well as outcome. And these related disorders that include body dysmorphia, hypochondriasis, the eating disorders, trichotillomania, and body-focused repetitive behaviors. How to assess for a differential diagnosis. So what you want to do is you want to rule out malingering or factitious disorders. You want to rule out substance abuse because many substances can bring on anxiety and ruminative thoughts. You also want to rule out disorder due to a general medical condition. And you have to determine the primary disorder. So if someone presents with a comorbid OCD depression diagnosis, what is the primary disorder? Is someone not functioning because of OCD thoughts, or is someone not functioning due to severe depressive characteristics, such as feelings of hopelessness, worthlessness, suicidal ideation? So you have to make the distinction because what you're going to treat first is the primary. And you have to distinguish what comes first. Did the OCD come first or did the depression come first? And there are differential adjustment disorders that can look like OCD. Someone who has just made a very, very important life decision can start to wonder a lot about that decision. Was it the right decision? Was it the wrong decision? And demonstrate inability to make decisions and choices. So you want to assess whether a big change has happened recently in that person's life. And is it truly a mental disorder? So very, very important is to look for degree of impairment. Many people experience intrusive thoughts, impulse, and many people have subclinical characteristics of OCD. So somebody that has an intrusive thought that they could harm somebody might say, oh, where did that thought come from? And forget about it. And they do not experience any degree of impairment. So you want to make sure when you administer any of these assessment instruments that you take into account the degree of impairment. Now we're going to talk a little bit about diversity and difficulty in diagnosis in the general population. So there is a fear of social stigma. Many cultures stigmatize any kind of mental disorder. It's not acceptable in any way. So people that in these cultures that have a mental disorder will sometimes go years and years and years. They will suffer with it before getting help because of the stigma attached to it. In many communities, there is insufficient OCD specialists in the area. So many people can't get the help they need, even if they can see a therapist, because many therapists are not adequately trained. And if you get bad OCD advice, you could get much worse. I once had a client who was a minority client and had a fear that she was a homosexual. She was not, but had a fear that she was. She went to a therapist who was not trained in OCD, who told her that he thought perhaps she really was, and it was something from her past that she was repressing. And it turned into a disaster situation for her, which ended up in her taking time off from work and not dating for several years because of her fear. And she wasn't accurately diagnosed until she went to an OCD specialist. There's a lack of awareness in the public of what OCD is. People think, oh, I'm so OCD today, and oh, I have to wash my hands. Oh, I'm so OCD. There is a real awareness, a lack of awareness of what just OCD is and what is not. There's inadequate mental health training in general in our country. Treatment costs can be exorbitant, even if you have insurance, because copays, some copays are $50, $35. In a family on a strict budget, this can prevent someone from getting help, even with insurance. And then, of course, there's a lack of insurance. And then what does somebody do? Possibly they could go someplace that can give pro bono care, but that's not very common. And it is very difficult for someone in a poor socioeconomic area to have insurance and to get the adequate help that he or she needs. There are many barriers for minority populations. There is a cultural stigma attached to it. Being labeled mentally ill. The cultural stigma being, if you are mentally ill, there is something seriously wrong with you. You will not be able to get well. And if you go to see a therapist, there's something very wrong with you. Very much a distrust of healthcare professionals. Many cultures feel that the therapist is not culturally competent enough to assess them adequately, and so therefore don't go, because mistakes are made many times in treatments with the therapist that may be not culturally aware and may make an intervention suggestion that is the complete antithesis of what this person's culture dictates. And we'll talk a little bit more about that as well. Many minority populations feel that there is a discrimination, a racism, and a bias in a healthcare setting, which is why cultural competency is extremely important. Many cultures rely on alternative support, rituals to get rid of evil spirits, religion. Many people that are devout will seek help from their local religious leader rather than a therapist. Many times there are language and communication barriers. So what do you do if you are a Spanish-speaking person, or Chinese or Italian, and you only have English as a second language? Where do you go to get help? There really is not a whole plethora of adequately trained therapists that can speak Italian, Spanish, Chinese, or any of the languages that are a problem for people who only use English as a second language. Many people have a lack of transportation, so there's no way to get to a therapist. A lot of therapy offices are in the heart of the city, or they're all the way far out in the suburbs, and people have no way of getting there. There are childcare challenges. So, for instance, if someone is a parent and has young children and has nowhere to get that child to daycare, they can very well take a child with them to daycare, because if they, they can't take the child with them to the therapy office, because if they do, if the child is old enough to understand what the problem is, there's no privacy. And then if the child is so young, the child could be very disruptive. So childcare is a challenge for many, many people. There is also the fear of losing a job if taking time off from work. Many times employers are not so sympathetic and they don't allow people to take time off from work. So what do? Sometimes therapists that are in your area don't have night hours, or they don't have Saturday hours, and you can't take time off from work. So that limits the amount of time that you have available to go see a therapist. And again, I just want to talk about the lack of culturally competent therapists, because many times, therapists can lose a client and not know why. And it could be because of a lack of cultural competency. So I really ask everyone that is a mental health counselor to do the continuing ed in cultural competency, because it's very important to know your client and to also meet your client where they're at. Also, mental health systems are not sensitive many times to minority values and norms. And again, cultural competency really comes into play if you're aware of what your client's cultural beliefs are, then you are way more likely to treat that client with appropriate interventions. So that pretty much wraps up the assessment. For further information on finding treatment providers who provide empirically supported treatments, I recommend the International Obsessive Compulsive Foundation, www.iocdf.org, the Association of Behavioral and Cognitive Therapies, www.abct.org, the New Jersey Association of Cognitive Behavioral Therapies, www.nj-act.org. Upcoming trainings include ERP trainings on Friday. I believe it's the third Friday of the month. And Dr. Dina Siegel, I believe, will be giving our next ERP training for OCD. Thank you so much for joining me. It was a pleasure to talk to you about assessment in OCD.